All right. Good afternoon, everybody. I'm Thomas Emuh, and I'll be presenting on routine side tests. So routine side test covers case history, visual acuity, and cover test, motility test, but I'll be majoring on refraction. I will also have oculomotor balance tests, external examination, internal examination, and recommendation. So we'll start with case history. Case history covers your reason for visits. That's where you chat with your patient, ocular history, health history, medication, family ocular and health history. A way I do my test to make it easy and fast. So like I group them, taking visual acuities. Imagine you've taken distance visual acuity, right eye, left eye. As soon as you've done that, because you know when you're doing your cover test, you want to take a target. There's one line bigger than the smallest, the worst visual acuity you've got. So just do your distance visual cover test after your distance visual acuity. And then when you do the near, do the cover test, it makes it a smoother test and it's faster. When you do motility as well, pupillary reflex test as well, do both of them, like they go hand in hand. And then next it comes to the refraction. So a very important bit when it comes to refraction, a trial frame, aligning it to the patient's eyes. So take the PD of the patient, center your trial frame to the eyes of the patient, both with the PD, and then do the vertical centration as well, which is very important, especially if it's a high prescription. So I've got a red line going across the eye and the trial frame. Normally I use a thread to align the trial frame to the pupils of the eye, just to make sure it's aligned, because if a patient has a high prescription and you don't do this, you're going to introduce vertical prisms, which would affect your test at the end of it when we come to fixation disparity. So we'll get into it, retinoscopy and subjective refraction. When it comes to kids and people who have a challenge making decisions or people who don't speak, I just go for retinoscopy. If there's a fluctuation in accommodation, cyclopentolate does it for kids, wait 45 minutes after the drops, and then do your ret or auto-refraction. So spherical refraction, like we do, we test the right eye first, occlude the left eye. So there's considerations here. If it's a new patient or there's a large change in prescription, this is what I do, none. But if it's an old patient, someone I've seen before, and I expect good visual acuity, maybe not much change in visual acuity, I just go straight for a binocular refraction. And doing a binocular refraction, what I do is occlude. Like I'm testing the right eye. The left eye, I blur the vision to about 612, test the right eye. That means I've completed my balancing and all of that on the right eye. And I swap the same when I'm done with the right eye, test the left eye with the right eye blurred to about 612. Okay, so considerations when I'm doing your refraction. When you're asking questions about clarity of vision and all of that, I look at the smallest line. And when we're looking at the smallest line, I focus on a few letters, not all the letters on the line. So we'll start with a plus lens and ask the right questions. So I've got a chart there. So imagine the patient is reading up to vision arcade. So AR, that's where he stops, not being able to reach the next line. So pick like 2 letters, change your lens. So for say increase plus 025 and ask the patient, are those letters, because that's where the patient can read up to. Do they look clearer or is it more blurred? And you make your decision based on that and not just asking based on the whole line, because it makes it more difficult. We've got groups of patients, like when you're talking about refraction doing the plus lens side. First thing to consider, is there reduced accommodation or the patient has no accommodation? The question is it better or worse? If the patient has active accommodation like teenagers, that can respond to you. When you're dealing with plus lenses, the question would be, say they can read, if they have a plus refractive error, the vision is quite good, even though they have a lot of a refractive error. It's just there would be strain with the refraction or refractive error. So when you put your lenses, the vision might not be worse or anything. So the question should be, are the letters or what you're looking at, is it just the same or is it worse when I add a lens? So I'm increasing the plus lens, and you're asking, what you're seeing is, has it got worse or is it just the same? When it comes to a minus lens, it's a different case. So for patients with reduced accommodation, no accommodation, same goes, is it better or worse? For people with active accommodation, the question is, so you're looking at a line, is it definitely clearer, or do the letters go smaller or and darker? If it's definitely clearer, it means they need the lens. If they tell you the letters go smaller and darker, it means you're actually stimulating accommodation over minusing the patient, and you don't want to do that. So once you've reached your end point for spherical refraction, you could use the red, green, different methods you use for that. We'll get to the cylinder refining. Some people would say start by reducing your best spherical correction by 0.25. When I use a Jackson cross cylinder when it comes to cylinder refining, you have to be specific about the targets used. So on the presentation there, I've got two sets of targets. So either use round dots or like the circular rings. If you don't have any of that, you look at the smallest line the patient has been able to achieve, go one line above that. If you can place a circular target like an O, that works. And you need to ask the right question. Okay, so we'll start with refining the axis first. And the question is, which option makes the target more rounded and clearer? And then a few more rules about Jackson cross cylinder. When you're refining and you've increased or you've changed this cylindrical power by about 0.50, you need to compensate the spherical prescription by 0.25. So opposite signs. So say we started at minus 0.5 and you've gone to a -1. You need to increase the spherical prescription. Say, assuming the spherical prescription was +1, you need to go to a +1.25, all right? And then at the end of your refining of axis, you go to refining power. If the power change is more than 0.50, it's a good idea to just check your axis again. And then one critical question about JCC, this is from experience, do you give the full cylinder found? It's a bit tricky for a patient, say is a returning patient, and you found the full cylinder with Jackson cross cylinder, and the patient has been wearing that cylinder and being happy with it, I would give it. If it's a new patient, I'll possibly adjust, maybe give slightly less. So if you, like with the JCC, you're refining the power and you get a reversal. So say you've been increasing 0.25 from -0.50, that's your starting point, you increase to about 1. And then your next question you ask, and the patient says an 0.75 is better. I'll go back to an 0.75. Then one other important thing I found out about Jackson cross cylinder, finding out whether the patient is, the responses from your patient is reliable. So I have a picture on the slide here. So number 1 is question 1 on the left side. So you've got the minus seal to the left. And then that's option 1. Then option 2, minus seal to the right. So like minus, and we're refining an axis of say 90 degrees. So option 1 or 2, which is better. Say the patient picks option 2. It means we're meant to go from 90 to about 30 degrees, say 60. I would ask the same question with the same, without changing the axis, because it's the first I'm doing for the patient. So the previous option 1 becomes my option 2. So look at the second diagram. And then the previous option 2 becomes my option 1. And I ask the same question. It's just to check for consistency of response. If I get a consistent response, then I'll go ahead with it. If I don't get a consistent response, I would find something else to do, possibly maybe rely on your RET. So your final sphere and binocular balance. So say you've tested the first eye, which is the right eye. For a new patient, you occluded the left eye. When you're done with the cylindrical refraction, check your sphere again. Once you're done with that, you're going to test the left eye. So this time you're thinking, okay, what's the best visual acuity achieved? Say 6.5. The other eye, am I expecting 6.5? Maybe yes. And then what's the RET result given me for the left eye? Say maybe 7.5. Then I'll do a binocular refraction, blur the right eye to about 6.12, and then start the whole process again. So refine your sphere. While I'm refining my cylinder, I always do a monocular because I found the results vary, and patients are more comfortable with the ones I found when I did the test monocularly. So that's the JCC, all right? So when you're done with all the refining, you found for the left eye now, you found your sphere, you found your seal, you refined the sphere again, and you've done it binocularly. That means you don't need to do a binocular balance. But for a patient you haven't done it binocularly, yeah, you go ahead, blur one eye to, say, blur the left eye to 6.12, adjust the prescription for the right eye, blur the right eye to 6.12, adjust the prescription for the left eye, and that says you're done. So we'll go to oculomotor balance. I use fixation disparity test, which is a target you see there, the OXO, very popular one. And with the fixation disparity, a few points to note. You're meant to refine the vertical disparity first because it affects your horizontal disparity. So say you do a test and you found the vertical disparity of, say, 1 prism delta base up in the right eye or 2 prism delta base up in the right eye. You might find when you check the horizontal, there's no disparity. But if you start with the horizontal, you probably find initially there was a horizontal disparity. And then, so you get a horizontal, say maybe 2 prism base in, and then you do your vertical. Instead of getting like the 2 base up, you might get like 1 or something, and that might not be correct. So once done with that, we'll go to external examination, slit lamp. Some people could do this first. Whichever way you choose, it's fine. Do it at the beginning or at the end, it doesn't matter. So whether you use a slit lamp or pen light, well, best practice slit lamp or thermoscope, slit lamp, and then with the Volk lens for internal examination. So we'll come to the final thoughts. So you've completed your test. Let's say it's a child, and the prescription is a plus prescription, is a high power. Does the child require any correction? Do you require partial correction, full correction? So the things you should consider would be, for a child, are they getting any headaches, any eye strain? Are they struggling with their reading? And what's the amount of the prescription? If there's headaches, there's eye strain, no binocular vision problems, partial correction might do. If there's a binocular vision problem, then we're thinking full correction. For a myope, there's a prescription, significant, then you should give full correction because partial correction could lead to progression of myopia. Now we're thinking for adults, hyperope or myope, is there any prescription required? If it's an old patient or a returning patient, do they need a change? So say a patient comes in, anno 25 change, or previous with the current glasses, there's no complaint, no issues. Would you want to change that? I'd rather leave it. If it's the first time the patient is coming in, is a hyperope, they're having problems, are you going to give the full prescription? They might not adapt to that. Even if a myope as well, full prescription might cause headaches as well. If you're giving prisms, we know what to do. Like prisms should be minimum prism to cause alignment of the targets, fixation disparity targets. Do you need to refer the patient? So those are the thoughts.